Okay, class, today we're going to be looking at sinus tachycardia. Sinus meaning it's coming from the sinus node. So we would still have that sinus P wave that's normal, rounded, and symmetrical. Tachy means fast, and cardia means heart, so we're going to be talking about a fast heart rate. Now, we said that the sinus node is the normal pacemaker of the heart because it fires at 60 to 100. Whatever has the fastest rate, that is what's going to pace the heart. Now the sinus node, the upper limit of the sinus node is 160 to 180 beats per minute. Some books will say 160, some will say 180, but it's in that range. Sometimes when things are firing so fast, the P from the new beat starts blending with the T wave from the beat before it. So you have a P and T blending together, making your components really difficult to see. If the QRS is narrow and you're not really sure if you have a P there or not, we call it a supraventricular tachycardia, which we'll be spending a lot more time on next week talking about. So when we're looking at our tachycardia, if I look at this example here, I have a regular rhythm. QRS to QRS to QRS to QRS is a regular rhythm. My rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, because all of my QRS lands in those strips, so my rate would be 130. I have one P wave for each and every QRS, and my P wave looks normal, rounded, and symmetrical as it's going across the screen. My PR interval looks like this one here starts on the dark line, and remember each of these baby boxes is 0.04 seconds. So it looks like I have 1, 2, 3, it looks like just right almost at 4 little boxes, I think. It's kind of hard for me to see them without blowing this up, which if I had 4 boxes, it would be 0.16, and it looks like it's the same all the way across the strip. My QRS, I measure from where the Q dips down to where the S comes back to the isoelectric line, and it looks like it's almost 2 boxes there, so that would be 0.08. And if I'm looking at my QT interval here, it looks like, now remember one big box has got 5 little ones in it, so there's 5, 6, 7, it looks like 8 little boxes, so that would be 0.32. And normal is 0.40 or less in normal heart rate ranges. Now in tachycardias, usually your QT interval will shorten a little bit, and in bradycardias, your slow rhythms, it will lengthen out. So we will have a regular rhythm with a sinus tachycardia. Our rate will be over 100. So 100 is normal. 101 and higher becomes a tachycardia. But again, usually 160, 180 is our max on that. We will have one P wave for each and every QRS, and we'll have normal PR intervals, QRS intervals, and QT intervals. Now, it's abbreviated ST for sinus tach, but always make sure you put your rate, because sinus tach at 110 versus sinus tach at 160, you're going to see 2 different things with your patients. So we always put the rate down. So on this example here, this is only a 3-second strip. I have 1, 2, 3, 4, 5, 6, 7, so that would be a rate of 140. Now you can see here how my P and my T are blending together. Now sometimes they blend so much you really can't tell if you have a P wave there. This one looks like a P wave still to me. It looks like I have a nice normal rounded P wave. It's just sitting really close here to that T wave. My PR interval, if I look at my little boxes, it looks like I'm 1, 2, 3, 3.5, almost 4 boxes. So that would be, you're looking at 0.14, 0.16. QRS, it looks like you are about 2 boxes here, so 0.08. So I would have ST at 140. This example here, regular rhythm, QRS to QRS to QRS to QRS is regular. In 6 seconds, I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. That one, the whole QRS doesn't land in it, so I would count that as 130. It looks like I have a P wave for each and every QRS. P wave looks, even though it doesn't look the same as that last one, it's rounded. It looks the same as it's going across the strip. Kind of hard. My little boxes are a little blurry, but my PR interval doesn't look like it's overly long. QRS looks like it's nice and narrow, so that would be ST at 130. Now, F up on the monitor, it says 125. That's okay, because it's going to count every beat in 1 full minute. So it's going to get 126, 125. You might get 120 one strip you run and 130 the next time you run it, because we're only doing ours for a 6-second span of time. With this example here, I have a regular rhythm again. My rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. So 140. I have a P wave for each and every QRS. Looks like my PR interval is okay. It looks like it is 1, 2, 3. It looks like it's almost 4 boxes, so 0.16. My QRS looks like it's about a box and a half, so 0.06. And my QT interval looks like it is 5, 6, 7, about 7 boxes, so 0.28. So it would be ST at 140, I think I said. This top example here, again, I have a regular rhythm, QRS to QRS to QRS to QRS is regular. My rate in 6 seconds, this one doesn't fall in my hash marks here, so it would be 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, so 150. It looks like I still have a P wave. My P and my T are starting to blend together, but it still looks like that looks like a P wave to me. So it looks like I have a P wave for each and every QRS, and my PR interval looks like it's 1, 2, it's not even, it doesn't even look like it's quite 3. And the reason that happens is because this P and the T have blended together. Normally your P wave would be sloping down. It would start from the isoelectric line down here. This one, I can't really, I'm having to count it from up here, so it may actually look a little bit shorter just because of that. My QRS, when you have a normal size QRS, and remember normal size QRS is 0.06 to 0.11, your QRS looks narrow as it's going across the screen. Okay, it looks like it's a narrow, even a normal size QRS looks narrow as it's going across the screen. So my QRS here looks like it's about 1.5 boxes, so about 0.06. So I would have ST at 150. Where this one here, now this one here, my entire QRS doesn't land in it, so I would not count that. I would count here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, so 110. I have a P wave, and this one it's really easy, obviously, to see my P wave. I have a P wave for each and every QRS. It looks rounded, symmetrical, the same, so I know it's coming from the sinus node. My PR interval looks like it is 1, 2, 3, just a hair over 3 boxes, so it's about 0.14. QRS looks like it's a box and a half, so 0.06. And QT looks like it is 6, 7. It looks like it's just a hair over 7, so 0.30. So this one would be sinus tach at 110. And what I would expect to see with this patient at a sinus tach at 110 versus a sinus tach at 150, that's one of the reasons you always want to put the rate down. Okay, the faster the rates are, usually the more compromised our patient can become. Now this is a sinus tachycardia looking at it from a 12-lead ECG. And you can tell that on some of these, the P waves are easier to distinguish. Some of them QRS measurements are a little bit easier to get. Generally, lead 2 is what we do our monitoring in. But anytime you have abnormal rhythms, it's not a bad idea to get a 12-lead ECG, though I will say sinus tachycardia, there's a lot of things that cause a sinus tachycardia. You go to the gym, you're going to get a sinus tachycardia while you're working out. You get really scared, really nervous about something, you're going to get a sinus tachycardia during that time. And that's okay. It's all right for your heart rate to go up. You have your fight or flight syndrome where you that vagus nerve, when you are, sorry, not your vagus nerve being stimulated, that would cause a slow heart rate. But when you are really scared, you're basically what's going to happen is your fight or flight's going to kick in, and you're going to have that release of some adrenaline, and it's going to let you either run or fight or flee, whatever you need to do for that circumstance. So it's okay for your heart rate to go fast. So it's not that I need to get a 12-lead ECG every time I see a sinus tachycardia, but if the person's really tacking at rest and they're not really sure what's going on, they may want you to get one for that. So what causes a sinus tachycardia? It's normal in infancy and early childhood. So when I'm telling you that a normal heart rate is 60 to 100 beats, that is 60 to 100 beats for an adult. In an infant, we would expect them to be 160 to 180. That would not be alarming to us. If I had an infant who was 100, I would be worried. Normal in anxiety and excitement. But there's also pharmacological reasons it happens. So for instance, atropine. Atropine is a medication that we give for slow heart rates, but of course then it can cause a rebounding or effect of causing a tachycardia. Epinephrine. We give epinephrine when a person's having an allergic reaction, when they're having difficulty breathing sometimes. We can give it for slow heart rates. And so again, it can cause a tachycardia as a side effect of that. Caffeine, if you're drinking a lot of caffeine, it can make your heart rate go up. But there are also pathological reasons. The thing we have to remember is that it is not normal for adults to have tachycardia at rest. So if you get your patient, if you're working on a cardiac floor, a cardiac monitored floor, and you're getting your patient up and you're walking them for the first time in the hallway and their heart rate's 110, 120, I'm not going to be overly alarmed so long as they're doing okay, they feel okay, I get them back to bed, their heart rate comes back down. I know what caused it. Okay, normal. But if you have someone who's just laying in bed and they're tacking and they're 120, now they're 130, and they're just laying there in bed and they're not even exercising, there's nothing going on with them, something's happening to them. So some of the things that can cause a tachycardia: fever. If a person's running a fever, if a person's getting an infection, we want to look for the cause of it. Yes, we can give Tylenol, but we want to look for what's causing that fever. We should get a full set of vital signs, including temperature, pulse, respirations. We need to check blood pressure because when a person starts tacking really fast and they're dropping their cardiac output, if they're not, getting as much stroke volume and as much blood sent out, their blood pressure is going to drop. And then we also want to make sure we check an oxygen saturation. Are they hypoxic? Hypoxia is one of the common causes of tachycardia in an adult, so we want to make sure we're checking their O2 sat. Hemorrhage. Did they just come back from surgery? Did they just come back from having a cath lab procedure? Are they bleeding somewhere? I would want to start looking for signs of that. Because if possible, we want to treat the cause of a tachycardia. Our significance of a sinus tachycardia, well, if it's rapid and it's prolonged, it can lead to heart failure. You have to remember your heart fills during the diastolic phase. So during that resting phase is when your heart fills with blood. If your heart is beating fast and it doesn't have a diastolic phase to it, your stroke volume, how much blood you're pumping out with every beat, is going to be decreased. And so yes, your heart's beating fast, so it's trying to compensate, but it can only do that for a period of time. You're going to start dropping your cardiac output. And remember, when we have a decreased cardiac output, our symptomology, whether we have a decreased cardiac output from a bradycardia or a decreased cardiac output from a tachycardia, we tend to see altered level of consciousness, dizziness, lightheadedness, confusion, chest pain, shortness of breath, those hypotension. Those are some of the things that we're going to be looking for to see if they're struggling with this tachycardia. The other problem that we have is it increases the oxygen demands of the heart itself. So remember that your heart, those coronary arteries, we said they fill during the diastolic phase as well. So during the diastolic phase is when the coronary arteries get its oxygen blood flow. So if your heart's pumping and pumping really fast and you don't have much of a diastolic phase, your coronary arteries are not going to be filled as much. So you're not going to get as much oxygen to the heart muscle itself. But yet here it's working so fast, using up its oxygen. So that's going to lead to a more, just kind of rebound itself and continue to cause a problem. So we try to treat the underlying cause if possible. If not, we can use adenosine. Adenosine, we give 6 milligrams rapid IV push. Adenosine only has a very short half-life of 5 to 10 seconds. You push it in slow, it's going to be gone and dissipated before it even hits the heart. If it works, it's very dramatic, actually causes a nice long pause. Cardizem or diltiazem, which is a calcium channel blocker, we can give 15 to 20 milligrams IV push over 2 minutes. That one's a slow push, where the other one's a rapid push. And then beta blockers, your metoprolol, your atenolol, your propranolols, those can be given as well. Those are great for slowing the heart rate down as well. So we're going to go ahead and stop and take a little break here.